चढ़ा चढ़ाना ही है ना आपको।
कल कोई नहीं अंजलि, हो जाएगा। नहीं नहीं नहीं, iOS तो हो जाता है। हो गया ना, खराब हो गया ना।
calcified lesions without imaging, you don't do it? Okay. So imaging is a must. Khalid. Without imaging.
But not in the left main.
I think in 2023, Euro 4C group published an algorithm in ESC that you can go without imaging, but with some criteria doing calcified lesions. But this is not the best or the optimum way to go, but sometimes you can do without imaging.
Gurugram, with the PCR and the Euro Bifurcation Club.
Yeah, for us, yeah,
consensus.
we will. Yeah, our consensus is definitely to follow one class 1A indication for intracoronary imaging for left main PCI, especially if it's calcified, and some explanations for the negative results of the eclipse go also in that direction, that the rate of use was low, assessment of calcium was not based on imaging. So I believe if there is any subset that we can recommend strongly image guidance, it's left main with presence of calcium.
I think the important issue, though, here is you said the presence of calcification. Angiograpically, you may miss that calcification, so imaging is extremely important. You may think the lesion is not calcified until you get into the throes of underexpansion and problems secondary to the calcium being there.
So back to the case, Khalid, I see you're looking at that angiographic image and the haziness in that osteal LAD. I think you have a very good IBUS image. Are you happy with what you have right now, or are you still looking at it? I agree with you. I think that's a very fair statement. I agree with you.
Dr. Sobe, just like I know left main definitely yes I was, but it's the same thing, financial constraints in your country and in our country also, and we are not really able to do IVUS in obviously all the cases. Are you doing IVUS in all the cases back home?
Nowadays we are doing this in most of the cases because it's reimbursed by the insurance. It wasn't before. So regarding the private, yes, we have to discuss with the patient. It's not ad hoc. We have to make optimization, otherwise do cabbage. So he accepts the cost. Regarding the insurance, I have to write that this patient is in need of IVUS, so I do it. 2 or 3 years before, it wasn't like this. So I think we have a left main, which usually you need an IVUS. Calcification, usually you need an IVUS. So combination of both of them, I think it's not 2025 to do it without an imaging, to make what's known as optimization of your technique. You agree about this? I think Khalid, what will be the follow-up of your patients with it? This patient? Yes. In general, this heavily calcified, doing optimization, wrong procedures. Do you follow these patients or give these patients DAP for longer periods? This patient had an ACS only 12 months or more than 3 months? Only 12 months or 3 years? Our practice is 12 months. Okay. Any other questions? Because they already have.
But I think imaging will also help you to coordination up to if you do imaging and you know that you have very well established medical skills and you will do
Okay. Okay. Got it. Final comment.
Congratulations for the case, Dr. Khalid. I just wonder what's your routine practice if you got some results that is not in this patient particularly, but I mean in any patients for left main trunk stenosis that was treated percutaneously. When you schedule the patient for a routine coronary angiography?
I think this.
Yes. I know it's not recommended anymore as before, long time before, but when you feel like I need to take another angiography for this patient after 6 months, 9 months, 1 year.
Dr. Khalid, we come to the end. Dr. Khalid, Dr. Abdullah. I think this is a very good example of a classic case of calcification which needs IVUS and needs optimization and using what you have in your techniques in your core lab, whether the balloon technology or ablation technology. Thank you for the panelists, thank you for the audience, and thank you for the SCAI.
Great case. Thank you.
Take care of this one. Well done. Well done.
Well done.
Once upon a time, life used to be a Puritan process, and medicine used to be the science and art of healing. The medical profession was meant only for the few blessed ones, people with a passion to heal, working to earn something priceless, good karma. As India grew at an unbelievable pace, its people reveled in the glory and constantly challenged themselves for more. More work, more pleasure, more money, more consumerism, more stress, and more heart disease. A group of doctors with a passion to heal got together to stand up against disease. Vedanta Heart Institute was established.
It's about compassion.
Earning good karma.
Hello, can you hear me? Hello, good morning everyone there in SCAI. Ramesh.
Dr. Chandra, give us a second, please, so
Yeah,
the
sure.
audience can sit and,
Yeah.
and we can proceed with the next session. Let me introduce the panel. I'm Dr. Luis Guzman from Mary Washington. So, can you hear us?
Yes, we can hear you very well. Yes, please go ahead.
Okay, wonderful. So we have here a great panel. So we have Dr. Fletcher, Dr. Basir Hanif, Dr. Manish Parikh, Dr. Don Carroll, and Dr. Goran Stankovic. So please go ahead and present your team and present your case.
Okay.
I'm happy to have you at the SCAI 2025.
Thank you very much, Dr. Guzman, and the entire panel there. And I'm glad that we are able to present and show you a complex case from Medanta Medicity, and we are operating in New Delhi in India. And along with me is my team, Dr. Abhinav Chabra and Dr. Hani, and the entire team here for imaging and to help us in all these setups. So Dr. Hani is going to introduce this case quickly.
So this is a 71-year-old female with a long-standing history of hypertension and diabetes. She had history of recurrent angina since 2 years, and the chest pain and breathlessness on exertion. She underwent angiography in January 2025, where it showed that the LAD and circ were
So the
heavily
next slide,
calcified.
please. Next slide. Next slide.
Yeah, so we can see the angiography here. And post that the patient had POVA done to search, and however the stent could not be placed there, and following which the patient still had persistent angina. So we see the first shot today, and this
So
is
go
the
to
old
the
one.
fluoro images now, please. So
Correct.
this is today, and no, this is the earlier angiogram.
25
January. Yeah, this is 20 January,
Yeah.
and they tried to do a angioplasty to LAD, but they could not cross the lesion. But then they tried to do the circumflex. Again, they could not cross. They crossed the lesion, but they could not cross the stent. So this was the angiogram of January 25, but they tried to do some balloon dilatation of the circumflex. And so we now go to the today's fluoro image. Let's show you the first shot, please. So this is today. Go to the first shot. Yeah, yeah. So this is today's first shot. As you can see, the LED is the same, very heavily calcified vessel in the proximal to mid situation, and then the circ is also, again, as you already know that in Jan they could not put a stent. There is a recoil over there, and then that means also needs to be stented. The right is diseased, but it is an infarcted territory. EF is about 40%. So this is where we are, and so what we have done is we have planned to do a atherectomy here using orbital, and so the first vessel we have planned to do is the LAD. We have wired the vessel using the wiper wire, which is already there, and we have taken the this device which is in we tried to do IVUS first.
Okay.
Yeah, you see that we tried to do the IVUS just to know what exactly is happening in the proximal part. So show the IVUS images, please. But of course, OCT cannot be done because it is a very tight lesion and we will not see anything. So this is the proximal part of the LED which we tried to image. Show the this IVUS images, please. Just the proximal part, just to get some idea. And of course, as you can see that the catheter cannot be passed inside. So let me now show you. We have the wire inside and we have the orbital ready. So we'll start doing the first round of so here we are. Yeah. Speed. Should I increase? Stop. Yeah. So we have put the catheter with the glide in the proximal part, and now
So the OCT catheter cross the lesion or no?
not.
Oh, okay. You're like.
Yeah.
Okay.
So this is the orbital catheter which we are trying to cross, but as you can see there is a difficulty, and we will go slowly and hold the guide catheter, please. Yeah. Okay, ready? So this is with the speed of 80.
So how many RPMs are you now?
80.
So, yeah, tell us what is your normal approach on RPMs?
So the normal approach is if the vessel is less than 3.5, then we go with the 80, Otherwise, we go to 120. We can go to 120. But this artery is below 3, so we will not go. And that's what we wanted to check on the IVUS, whether it is below 3 or above 3. So that's why we
Is
are
there
not
any,
going.
is,
Yeah. So as
is
you
there any
saw,
protocol that you follow? How many runs you do before the
no,
device
I mean
pass?
basically we have to
Before
cross it.
doesn't pass to go to 120?
No, so we do that. We do it in bigger vessels, but not in the smaller vessels. So now again,
So how is the panel approach the CSI? So you do
so
go
you can
to higher?
see now it is in the middle part of the lesion, the distal part.
In nowadays, we try not to go to higher RPMs to prevent slow flow. Anybody
So you
wanna
can
comment?
see that it is a very tough lesion, and it is we are taking our time to go slowly, because if we push it too hard, sometimes the slow flow becomes the flow is
Yeah,
still
so this
fine.
orbital
You can see.
atherectomy is time dependent, and the slower you go,
Yeah,
the
so
better
we are
you'll
going
do.
slowly. Yeah, we are going slowly,
yeah.
and that's why and we are checking in between whether there is any slow flow happening or not. Okay. Yeah. Okay.
You know, I'll add to that, even with rotational atherectomy, it's time dependent. Again, you want to be meticulous and slow with your passes.
There is a question.
How would you make the difference between orbital and rotational in this situation? Why would you pick orbital over rotational?
Yeah, I think, these types of situations, at least for us, rotational seems to be the most commonly used because of our not only history with it and the fact that you've done more cases with it, but in many of these cases, either is fine depending on your comfort level. The main part is that you want to get the orbital where you want to get to, and that may take some time here because of the severe proximal calcification.
So I have a question for the panel. So I'm actually from a fairly underserved area, so we don't do any kind of anything like this. But as we expand our program, and we are faced with the choice of rotational versus orbital atherectomy, which, we have limited resources, which would we invest in initially? And not only invest, which is easier to pick up and learn as well, because, that's the other thing that you need to invest in it both
Just
from a
taking
human
time.
resources and a financial standpoint.
So Louis, what would you invest in if you had to pick one atherectomy device?
So I will normally I use, perhaps because of my age and the background, I do use rotational atherectomy much more often than CSI. I think it's very reliable. The only problem to me with the rotational atherectomy, to be honest, as compared with the CSI, is the wire. But other than the wire, I do believe that rotational atherectomy is very reliable, and it has a 25, 30 years of data behind.
So, Dr. Pravin, what was the reason, using CSI versus rotational atherectomy in this case?
Okay. So here the thing is that we can use even the rotablation. There is no issue with that, but we thought that probably it will be better to use a. Give me some termin, please. Yeah, some Brady here. Give some, because the patient is having some difficulty. Let me just manage this. Give some termin, please. Yeah.
Uh-oh.
Flow is okay. The patient is having some hypotension. Okay. Just a minute. Yeah. Intubate. Yeah. Okay. Let me just take it out.
If you feel uncomfortable, we can certainly go offline to do these things.
Yeah, you can go offline and then we can see.
So
I'm sorry that this happened, and we are going to continue here. So
we can discuss few things. In this case situation, would you consider doing a more simpler region like the circ one before going for LED in order to really have some kind of backup This is what I would have considered personally.
Can we cancel the images, please? Can we stop the
निकालो
Can you hold the
निकालो
transmission,
एक
please?
निकाल लो
transmission, please?
निकाल लो उसको और निकालो
The
और निकालो
technical support, can we
और
stop
निकालो
the
और पुश
transmission?
करो
Thank you. And the volume too.
बस ठीक है ठीक
No, that was
we
the last
still
time.
Came back,
This
yeah,
is the
it was
first
very
time.
severe.
Yeah.
It was very severe.
एक मिनट रुक जाओ एक
So
मिनट रुक
these are
जाओ
the
एक मिनट रुक
types of
जाओ
things
आरे
that
रिकॉर्डिंग
can
करना
happen in these cases. If you get slow flow, you saw there were profound ST depressions. You were occlusive with the atherectomy device, and it takes time to get to the mid LAD. And this is the problem with orbital, I think, is that it takes time to get down to where you want to get to, whereas rotational atherectomy with front cutting on the occasion is correct, but you've got to be ready if you have slow flow or no flow in a big LAD to be able to manage it.
Right. Yeah, the one comment I make too, if I recall the history correctly, the physiologic data showed us inferior
Fine cross.
ischemia, and the circumflex probably was more the culprit in terms of that. So I may have.
And give me a all-star wire. Fine all-star and fine cross. All-star तो थी अपने पास. दे दो. Fine cross दे दो.
That's another area that I would have concern about.
It's okay. The BP is okay now. BP is okay. Eh?
Absolutely.
सीधा करो.
Absolutely. We always
See the
check
straight
LV
color,
EDP.
straight.
If we are not putting in a device, we always check the EDP first and then proceed accordingly.
But however, even the ejection fraction is normal, the LVDP is normal. These things can happen.
It can. But if it is high, then you prepare it
of
accordingly.
course, of
That's
course.
why it's important.
So I think technically the problem here is that they stay too long into the LAD without removing the device backwards into the proximal LAD to allow flow in between runs. I think that is very important. They left the bird inside of the severe lesion, and that probably what happened in this patient.
हाथ ला रही है हाथ पकड़ना.
So after you pass the device, well, first, if the IVUS doesn't go, everybody would have go with rotational atherectomy directly, or you would have tried to do a small balloon to do an IVUS to have some additional information from the IVUS.
Well, you know, I think in the old days, if your balloon didn't pass, that was your IVUS. And so basically, and also angiographically, you saw a heavy burden of calcification here, even though IVUS is more sensitive, but I don't think there was any question with your small balloon not crossing and the angiogram. I'm not sure that.
And that small balloon may not be able to dilate it also. So I think one of the indications used to say that if you can't pass the IVUS, then the next step is you have to go with the atherectomy.
Yeah. Correct. No, I'm not saying that I'm not doing atherectomy, but so the second question is, you do CSI and eventually you do pass and you do the appropriate modification and hopefully decalcification. So you do IVUS after that, or in order to better understand the next step, or you just go directly with the balloon?
I will go for IVUS after that. Let's see what's going on.
Connect.
You know, again, I think we don't need to get too cute. This is a heavily calcified LAD. You do atherectomy, you take an appropriate size, reasonable non-compliant balloon, make sure that you've done the job with your atherectomy, make room, and then you do an IVUS run. Again, being obstructive for long periods of time isn't helping the patient. So, you know, what do you want to really know? Have you plaque modified? What's the dimension of the vessel? And what length stent do you need? And that's the way I would do it. So, you know, one pre, one post, after you've done what you need to do to modify the plaque.
Balloon.
Yeah, I can just echo what Dr. Parik just said. After ROTA, we always post-dilate with NC and then use imaging to see where is the landing zone, plaque burden less than 50%, what is the platform of the stent to take, the length of the stent, and then we start.
So you accept the balloon expansion as an indication that the plaque has been modified properly?
No, we don't say properly. We just say that rota per se is not sufficient to prepare the vessel.
No, what I say, the IVUS, the balloon expansion, I understand that you don't do the IVUS immediately after, but you do accept the balloon expansion as an expression of response, or you use the IVUS imaging that you're taking later?
Rota is defalking very partially. It's actually shaving the plaque, creates some small fractures, and then we use balloon to break this calcium. And then I use the established flow, perfuse the vessel, and I use imaging to understand how to plan further steps of procedure.
Okay. So I was trying to step by step. So let's assume that the IVUS shows that there is, the balloon did open, but the IVUS shows that there are calcium nodules that you know that when you try to put a stent might have some problems. So
14, 16, 18.
Using different plaque modification strategy at that point. You use a balloon to determine whether the stent will deliver. So what is the approach of the panel?
Well, I'd be concerned about ballooning a calcified nodule. I don't think that's going to modify it very much. One of the things that you might start to think about might be lithotripsy as an approach to do that, but I don't think I'd try balloon.
All right, so remember we did put this balloon and the balloon did expand it completely. And then you do the IVUS. Does the IVUS make you to do a different approach prior to stenting based on the findings, in spite of the fact that the balloon has expanded completely to the 1-to-1?
Deflate.
If you see a calcified nodule, I still would be concerned about whether or not your stent's going to fully expand. That would be my concern.
Go up. 2, 4, 6, 8, 10, 12. 14, 16,
After
18,
dilatation
20,
and IVUS, I
22, 24.
reevaluate what I have. As you said, if I see calcified nodule, I will upsize to IVL, most probably in the recent times, because of favorable outcome, not all.
IVL. So we can now connect back. Okay.
NC balloon, even after IVL, again
IVL.
NC balloon, but this time based on IVUS, I know the proper dimensions, so I don't
2.5
oversize,
IVL
but I know that I have to break this calcium in order to accommodate stent.
So you do the same thing in Pakistan?
Fortunately, we don't have an IVL available yet, but definitely I think calcium nodule is a very tricky situation, and ideally we should have IVL to really break that nodule.
Hello, can we connect now? Connect.
Okay, great. Dr. Chanda, you are live again. I'm glad that your patient is doing well.
Yeah, so the patient is okay now, the BP is fine. And you can show the last shot, please. Last shot. So what I did was, I took out the, this CSI, and then we changed this wire with a extra support wire, and then we dilated with a 2 millimeter balloon, because almost 3/4 or maybe 80% of the lesion was already atherectomized, and now I'm going to take a IVL, because distally there is a nodule which we want to break. So I think this may be a better idea to take a 2.5 IVL and then see how it works here. Okay, so sometimes we have to use synergy, device synergy.
Balloon, why not a bigger balloon?
Because the vessel is only 2.5. Because we saw in the the IVUS of the proximal segment, that's why we did the IVUS initially, that to see what will be our size, and that is why we could not even upside go to the higher RPMs on the orbital.
So you are going to do IVUS now, or you?
No, we will do IVUS, but first I am going to do a dilatation of the distal segment where we could not, we did a 2 millimeter balloon dilatation. We went to high atmospheres, and thereafter, so this is a, a 2.5, and I have taken a guide extension here as well so that I don't have difficulties in crossing. It will help. Yeah. Yeah. This is IVL. Okay. So even IVL is having difficulties in crossing. Okay. So I'll take this out. Yeah.
So what is the IVL balloon size? I'm sorry.
2.5. 2.5.
Yeah, I mean, there's not a surprise that this is not going down. So you're going to need to either prep more aggressively or have a guide assisted
So
delivery of this.
I
Otherwise, it's not
already
going to
have a
get to where you want.
guide assistance here. As you can see, this is the guide extension catheter. Yeah, so I expect this to happen, but we will see how it works.
And now that you inflate it, it's going to go even less.
I think you will have to prep it with a bigger balloon and then try to get it down if possible.
We will see if we can do it, gradually. 1, 2, 3, 4, 4, 4.
Pressure is down again.
Yeah. We'll do one round and then bring it down. Bring it out. Okay. Done. Deflate. I'll take it out.
Based on the ischemia that this patient was having priorly AVL here, it is concerning.
So we'll
perhaps
take it out.
This is a case that we were mentioning before, that support was a good alternative for this patient.
Yeah, give me a.
Do you have access to hemodynamic support devices?
Yeah, we have access. We have put a sheath on the opposite side. The pressure is coming up slowly. No problems. It will come up. Yeah. We'll wait for some time.
Yeah.
It's coming up. Yes. Now it is touching 100.
It looked to us that we would have go with a long balloon non-compliance trio at least into the long lesion and try to open that lesion first.
Yeah,
and then see what
2.5?
do an IVUS after that and try to understand what is the next step on the
it is
plaque
very clear that this is a calcium and there are nodules, etc. So we definitely have to pre-dilate. I'm doing some more pre-dilatations with a 2.5 balloon and see how it works. Okay. So this is a typical situation, definitely. Yeah. So you see the balloon has crossed. Go up. 2, 4, 6, 8, 10, 12, 14, 16, 18. Yeah, there is a nodule. Deflate. So it's gone. Very well. Good. Go up. 2, 4, 6, 8, 10, 12, 16, 18, 20. Okay, deflate. Okay, 20, 20. Deflate. Okay, so now we are seeing some headway with this pre-dilatation, and now the balloon is crossing a little bit better. Yeah. At this stage, we can try to see if we can cross this IVUS catheter. If not, then I will again take the IVL. The pressures are stable. So far everything seems okay. So we'll go step by step, no hurry. And so the most important thing is that we must have all kind of support devices for this kind of situation.
Yeah. If you go look at the picture you took last, it looks like the circ flow there was a tight lesion and the circ flow is down.
No,
I don't know if
circ flow is all right.
I would have considered putting in a wire and maybe just balloon it to make it less ischemic overall.
I mean, the circ flow is all right. It is flowing. In this view, because of the entire, it is because of the hypotension at that time it was looking like this. So let us look at this now. Let's show the IVUS, please.
Currently, right now, your pressure is good. Did you give any nitro before you did this IVUS run?
Yeah, I will see. Let me first see that. If in case BP remains okay, I don't want to give nitro at this stage. I will see how it looks. Look at this. It is like a, yeah. So IVUS catheter has gone to quite a reasonable length, and yeah, it's a tunnel. It's a tunnel. It's all 360 degrees. Yeah. So I don't want to keep it for a long time over there, because it is obstructing the flow. Yeah, I'll just take it out, and at this stage
Praveen.
I think we can, yeah, Ramesh.
Yeah, Praveen, thank you very much. I think this is definitely a very complex patient that you have started off, and I think if anyone can do it, it's you. It's a heavily calcified vessel, and whom you saved already from a cardiac arrest, and we're going to go ahead and proceed with probably your whatever you're planning to do.
Yes.
Dr. Peter Duffy has a question here from the audience. Just
Thank you. So if you haven't put a support device in prior to doing the procedure, would anybody consider putting the support device in at this point before proceeding further?
So Praveen has all the capabilities of doing impeller and ECMO and everything. Praveen, the question is, would you stop here first and do a mechanical circulatory support device before proceeding?
I mean, one can think of that, but the ejection fraction was okay. And this is, suddenly happened. So first of all, the most important thing is to maintain flow, which we did. And with maintenance of flow, within no time the BP picked up, and now we have the time, so we know how the patient is responding. So basically, it all depends upon how you want to take it forward. And here the BP is okay, everything seems to be under control. So we have we have access on the opposite side. If required, we have the support devices available here. We will do that, but right now the BP is quite good. You can show the blood pressure, this hemodynamics, please. And patient seems to be very stable at this time. So we expect these kind of things to happen in complex situations, but of course we are prepared. And it was a good question that whether we do it support now. We can wait, I think. Yeah. So the patient is tolerating it, and it's fine. So now
Okay,
we will take the
with this IVUS that Praveen, what Dr. Chandra has shown, how many on the panel would go for balloon strategy only or atherectomy?
So I don't think that you pass the lesion with the IVUS, correct? I didn't see the IVUS crossing the lesion to better understand what's going on.
No, we crossed the lesion up to almost to the distal part of the lesion, but distally it was facing some difficulties. So we didn't want to wait too long in this LAD, because still, like with the IVUS catheter, there was some, flow reduction, and I don't want to give too much ischemia to this patient. So that is why I pulled it out. And I want to keep the vessel flowing in between, and not try to, push too hard, because already she had such a, quite a stormy situation just now. So we'll go slowly, and here we have this
Don?
IVL again. Yeah.
Atherectomy or no atherectomy? Just by raise of hands from the panel, please.
So Ramesh,
atherectomy.
he already did atherectomy.
We did atherectomy.
Yeah.
He did orbital already.
But more atherectomy, or now would you go for?
You haven't done the job, so you need to do something.
Yeah, we are doing it.
Here.
So we are now.
He's got an IVL out, so he's going to try to do IVL.
Yeah, go up. 1, 2, 3, 4.
So one of the reasons that I was asking about that you didn't cross the distal portion,
Four.
because you have an IVL, but I do not know where to put that IVL. Like you want to put.
So yes, so we have to do the IVL. I'm doing the IVL in the distal part, because we did face difficulty in crossing the distal
really
part of the lesion.
Calcium nodule to say that I have to go to that particular area. From your balloon, I couldn't determine where to go either. And also based on the IVUS, it looked like the IVL should have been larger than a 2.5. The 2.5 probably will not really.
The interesting aspect of this is I have done now nearly more than 700 IVLs, and in some patients I have seen that if you get in contact with the vessel wall, then the IVL works. Even if it is a bigger vessel, it will give cracks inside, and then we can subsequently dilate with a bigger balloon. So that is one thing which we can do. Especially I try to do that in vessels which are tapered, and we have to do a long lesion like in this one. So we do this kind of approach, and it works.
So I think let Dr. Chandra work on this patient, and we'll switch to the other room and come back. Is that okay, Praveen?
Yes, that will be fine. Absolutely. That helps.
Okay, thank you very much.
Go up. 1, 2, 3, 4.
So I actually agree with Dr. Peter Duffy, and I would probably, that for me, this is a warning sign, and I survived once. Doesn't mean that you fool me once, fool me twice kind of situation. You shouldn't get fooled more. Put a mechanical circulatory support, because if you still want to do more atherectomy or any balloon, it still can cause slow flow and compromise. Rajneesh, can you hear us?
Hear you loud and clear.
Thank you. This is
Are we audible?
Ramesh here, and we have a great panel here. Okay.
Yeah, absolutely. We looked forward for this evening, and in fact, there are two challenging cases. One Praveen was just showing, and this is also equally challenging, because while the time we were waiting, so we just did few steps. So let me introduce this case. First, this is Dr. Rajneesh Kapoor and Dr. Himanshu Dabral. Dr. Sushil is here, Dr. Shyam, and full team is here, and Dr. Karan was also here, and then there are guys with the OCT and imaging also. So let's introduce our case. Can we have the slide, Sushil? Okay. So this is a patient who came to us yesterday, 55-year-old male patient, had episode of chest pain few days back, and there were ECG changes and troponins were mildly elevated. There is no other morbidity, but yes, the patient is quite obese. He's almost slightly more than 100 kgs, and this was acute coronary syndrome. Although echo was fine, echo showed normal LV function, normal RV function, valves were okay. And this is the angiogram. He hails from some city near to Delhi, so he got his angio done there. So this is the angio which we have done today, but we have seen that angio yesterday, and this is the angiogram. This is RA caudal view. Look at this, LED is very densely calcified, and I'll show you a AP cranial view. Next view.
Are they seeing it?
Are we?
We don't see the angio. Can you?
Okay.
Can we see the angio?
Yeah, please. Is it visible?
Now we have the angio.
Okay, please come the RA caudal shot, previous shot. Okay. Okay, so this is the first shot, and densely calcified LED and diffuse disease in LED, long segment, and then there is a high obtuse marginal coming from circumflex, which is also osteally diseased, which is also tight. So acute coronary syndrome, dense long segment LED calcified lesion, and a tight lesion at obtuse marginal. AP cranial, next shot. Okay. No, sure. Okay, this is the AP cranial. Look, so LED is a long segment diffuse disease and quite densely calcified. So while the time as I mentioned, we were waiting, I'll also like to show you a iliocaudal view. Please come the previous view. Okay. So just to show you that there is how's the ostium of LED. So looks like there is some space. We can actually do the stenting from ostium, LED ostium onwards. Next. So just to give you a further detailing of this case, we did OCT of the LED. We wired with a normal workhorse wire, all star. Next. Okay. So now look at this. There is a very tight lesion around a diagonal, and there is very tight lesion ahead also. we had a slight difficulty in wiring across that point of the diagonal tight lesion, I mean around the diagonal. And after this, we attempted OCT without any pre-dilatations. We thought if it goes, we'll have a clear picture without disturbing the LED, but we could only take the OCT around that septal. So it's a heavily calcified vessel. Next.
This was the farthest.
So this is the OCT, and we could reach this point only. It was not going beyond that point. And the reason is very clear, that distal marker of the OCT is the point of the maximum tightest lesion. So it was not crossing that point. So we did the OCT of that area from septal LED backwards. Please show that OCT. Just to give you clarification of the extent of calcification and whether the proximal LED is involved and ostium is involved. Can we have the OCT image? Can you see the OCT image?
Yeah, we can see it on a small screen.
Okay. Make it bigger.
No, so
Yeah. So look at it's almost a 300-degree calcification, and quite thickness of calcium is also big. So we are coming distally, proximal, from distal to proximal. Come to the ostium. No, don't move. Come back. Show the ostium of LED.
Ostium of LED.
Come back. Okay, so this is the ostium. This is a circumflex, and then left main. Okay. So this is how we are placed here. We know there is one tight lesion which we still have to conquer that point. So this is the case. I think we can have your inputs and then tell we further advanced with few steps, and then we tell how we have actually done the next steps. Dr. Ramesh?
Yeah, let's ask, go ahead from our panelists. And,
Dr. Kapoor, Goran speaking.
Hi, Goran.
Thank you for selecting. Nice to see you again, and we look forward to the case. So in uncrossable lesion with really very severe calcified throughout the LAD, but also I'm afraid inside the left main. I think in my view, this is a case to prepare lesion with rota, post-dilate, and then stent all the way into the left main. So maybe, of course, we can postpone that decision regarding the proximal landing zone, but before, I think we should, this is uncrossable lesion at the level of bifurcation. With rota, risk of occluding diagonal is relatively low. So my strategy would be rota, post-dilatation, repeat OCT, and then stenting.
I agree with that. So, yeah.
Manish?
Yeah, no, I totally agree with Goran here. This is a very heavily calcified mid-LAD. Orbital is a choice. I'd love to see what they did with orbital.